We are really excited and pleased and honored to be here with my longtime colleague, Erin Bohula, who is an investigator at the TIMI Group and was the co-PI of the super impactful VESALIUS CV trial that was presented today at the opening late-breaking clinical trial session here at Scientific Sessions 2025. Erin, thank you for being with us.
Thank you, Chiadi, for having me.
It's really wonderful. So, I think this obviously is built on a background of really impactful prior research around PCSK9 inhibitors. So why don't you help our audience just put that in context, the prior research and what was the unanswered question we were addressing here.
Yeah, absolutely. And I would even take a step further back, which is with statin therapies. We know, we obviously know that treating LDL with statin, both in the primary and secondary prevention population, is helpful in terms of preventing events. But where the data lies with the PCSK9 inhibitors historically is in a very high risk population. So patients who've had, either a recent ACS event or a prior MI or prior stroke or symptomatic PAD. And there we saw that PCSK9 inhibitors, through lowering LDL, improved cardiovascular outcomes, but we really didn't have any data before VESALIUS on that lower risk population. So patients who have athero, who haven't had a prior event, or even patients who don't have atherosclerosis but have features that make them high risk for development of disease. And that's really where we focused with the VESALIUS CV study.
Well, it's very helpful because now, there is a lot more focus these days on trying to understand, especially with the increasing array of tools we have at our disposal and the ability to lower LDL more, where should we be more aggressive? And is there some benefit to targeting people before that MI or that stroke? Now, how did you pick this specific population? There's a concept, a phrase you all have used of high risk diabetes. So can you tell us how you conceptualize that?
Yeah, absolutely. Well, we really, I would say, kind of have two different categories of patients in here. We have patients who have atherosclerosis. They have some evidence of atherosclerosis, either coronary disease, cerebrovascular disease, peripheral arterial disease, but again, haven't had one of these major events of MI or stroke. And so that's one population. And then another is a population of high-risk diabetes. And how we define that were, patients who had diabetes with microvascular disease or long duration of diabetes, so at least 10 years, or if they used insulin chronically. So kind of, there's a larger world of patients with diabetes, and we focused on those who are a little bit higher risk for development of future atherosclerosis.
Yeah, that's very helpful. So we have these high-risk populations, and now you're basically testing in the context of these high-risk populations without prior MI or stroke. Tell us about the top-line results.
Yeah, we had dual primary endpoints. The first was a 3-point composite of coronary heart disease death, MI or ischemic stroke, and the second was a 4-point composite, which is all of those things plus ischemia-driven arterial revascularization. And the addition of evolocumab in this patient population, we've talked about, there was a 25% relative risk reduction in the 3-point composite, quite significant in terms of p-value, and a 19% reduction in the 4-point MACE composite, again, highly significant. So essentially, we were able to show that evolocumab in this population prevents the first event for a patient.
And for those of you who were not at opening session, when those top-line results were presented, there was actually applause because there was so much excitement at such a really substantial, clinically important result. Now, a couple of things. So first of all, there was a sub-study that had LDL LDL measurements, and I think you were able to get some insight into how low the LDL got in the population who was receiving evolocumab.
Yeah, so we had in about 2,000 of the roughly 12,000 patients, we had a sub-study where we followed LDL levels over time. And patients started in that sub-study with an LDL of around 115 milligrams per deciliter, and those in the evolocumab arm dropped to 45 milligrams per deciliter. So a substantial drop, about a 55% reduction, or in absolute terms, 63 milligrams per deciliter. So, a pretty profound reduction, which was maintained throughout the course of the study.
Yeah, and then, there was lots of other secondary outcomes that were also affected as well, and remarkably, there was actually lower rates of both cardiovascular mortality and also all-cause mortality in the group receiving the PCSK9 inhibitor, but that was not considered statistically significant. Can you explain to the audience why?
Yeah, no, absolutely. So when we set up the study, we had our two primary endpoints, and then if those were significant, then we passed our alpha, as we say. We were able to then go on and test our key secondary endpoints. And we had a hierarchy of those, just a list where we would test them sequentially, the first and second and third. If anything was not significant along that hierarchy, then anything that falls below that in the testing order then has to be considered sort of hypothesis generating or exploratory. And the hazard ratio for coronary heart disease death was 0.89, but the upper bound was above 1. And cardiovascular death and all-cause death were below that in the hierarchy. But as you highlight, there were nominally significant results there, about a 20-21% lower rates for both of those, with a p-value, again, that was less than 0.05, but nominal.
Just sticking on that for a moment, this trial was unique, not just in terms of the patient population, but also with regards to the duration of the trial. And do you think that played a role in why we might be seeing even more profound outcome differences between the two arms here?
100%, at least that's my hypothesis. I mean, I think in terms of mortality, what we know from the statin trials is it takes time for the curves to diverge, for you to see benefit in terms of mortality on the order of 1 to 2 years. And here our curves only start to diverge for all-cause mortality about 1.5 years. And so I think, and the duration of follow-up in the study was 4.6 years. The prior PCSK9 studies were on the order of 2 to 3 years. So Fourier was 2.2. Odyssey Outcomes was a little bit under 3. And I think it's just really important. There is a lag in being able to observe the benefit in terms of time delay, and you just need a longer study. And I actually think that's relevant even for the non-fatal events too. We've seen from the statin studies, from the CTT meta-analyses, that at first you don't see much benefit, and as the years progress, you see more and more and more. So you kind of get the maximal benefit over time. And our findings for the 3-point and 4-point MACE composite were, in terms of this, I should say, the CTT meta-analysis endpoints, were right on that curve. Yeah. And I think that's because, again, we had similar duration of follow-up to the CTT. Yeah, whereas the prior PCSK9 inhibitor studies were just shorter, and so they just didn't have the benefit of being able to sort of amass the magnitude of benefit over time.
That's very helpful context. Now, the other piece that's very interesting and a little bit challenging as people are trying to interpret this, it doesn't fit neatly into one bucket as some other trials do, because you don't just have, you have seemingly a mix of some patients who have had prior cabbages or prior PCIs, or have atherosclerosis identified through other means, and then you also have some just high-risk patients who don't have any atherosclerosis. So it's both a high-risk primary prevention population and a somewhat lower-risk secondary prevention population. Was that purposeful?
It was intentional. We were trying to move the needle and sort of study a population that was lower risk, and we thought it was important to include both of those. I would say when we were trying to simply describe these patients, we called them a 1.5 risk, not a primary, not a secondary. They're kind of somewhere in there. But that was intentional. We thought it was important. I mean, this is a large population of patients that we see all the time, and we wanted to sort of include the range. It certainly does complicate the conversation a little bit, because as you say, it is a bit of a mix, but it was intentional.
No, but you're right. Obviously, the population is growing. As you know, American Heart Association is focused a lot on CKM syndrome, and this population with high-risk diabetes and early atherosclerosis very much fits into that construct. So I think that's really, really important. Now, one piece that comes up is that this population, the majority of them were receiving high-intensity statin therapy, but not that many, were on ezetimibe, and also their LDLs were relatively somewhat elevated in the 120 range at baseline, and whether we would see the same results in a population that was more aggressively treated at baseline. So what are your thoughts about that?
Yeah, it's a really good point. I mean, I guess in terms of the background lipid lowering therapy, it depends. It's sort of the eye of the beholder. 20% we feel like is pretty good, because in prior trials it tends not to be. Yeah, it tends not to be that high. But I think probably another way to look at it is say that we had 72% who are on high intensity regimen, which means a regimen that's expected to drop LDL by at least 50%. So pretty aggressive background lipid lowering therapy. So I think that that we're quite happy with the standard of care in this trial. But your point is well taken, is that nevertheless, we had high lipid entry criteria, and so the LDLs at baseline were quite high. But I guess what I would say is, in the treatment arm, they got down to 45 milligrams per deciliter. And so I think that's really kind of the aim, is to say, we got it very, very low, and that's probably what the goal should be going forward, is in a patient population like the one studied here, we should just be aiming for something very low. If you start, of course I can't speak directly to those, who started at 80 because they were not included in our study, but it's sort of reasonable to say, well, maybe that person should still be trying to get them down into that into that range that we had here.
Well, let's get into the to end with here talking about the implications for clinical practice, and I think on two lines. One is diagnostically and one is therapeutically. So the identification of these patients. Many of them may have been identified incidentally, or they may have just had a prior history. So what do you think this means for how we need to be identifying atherosclerosis or high risk in our patient populations to consider patients where more aggressive therapy may be warranted?
Yeah, I think that's the key, right? Is that these individuals, they were found. Maybe they did just incident. They had a coronary CT and were found to have some coronary lesions. But I do think it speaks to the importance of being aggressive and identifying these patients, because now here we have data to suggest that there's benefit to being very aggressive in modifying their risk factors, specifically lowering LDL. So I do think it sort of puts the onus on us to try to find these individuals, and to be looking a little bit harder for them, because we know we can help them.
Yeah. So obviously this trial demonstrates, regardless of necessarily where we start, that the LDL lowering had a clinical benefit that was quite substantial for this patient population. Maybe we could say a little bit about cost effectiveness here and think about, obviously we don't know this yet, this is very early, but how we think about where this is going to have the most practical benefit in terms of number needed to treat. Are you guys going to maybe look at subsets of the population? Like, so we have high risk diabetes, we have atherosclerosis. It might be that the combination of those together, there may be some really high absolute risk and a lot of potential benefit we can get from an absolute risk reduction standpoint.
No, totally agree. And I guess, at the top level for the overall trial, the number needed to treat for the 3-point composite was about 55, and that's over 5 years. Yeah, and the number needed to treat for the 4-point composite, which included revascularization, was in the mid-30s, 36, I believe. And again, that's over 5 years. But I do think it's always important to consider, where you can have even more bang for your buck if there are subpopulations where there's benefit. Interestingly, the group, the number needed to treat is actually pretty similar between those with qualifying atherosclerosis and those with high-risk diabetes without
that's pretty
qualifying.
Remarkable.
It is, isn't it?
Yeah.
So it's again, maybe it's primary prevention. They don't have known athero, but they're very high risk, and their number needed to treat is in fact pretty similar, to those, and in fact maybe even slightly better than those with qualifying athero.
It speaks to the importance of, in the context of high risk, how important of a risk equivalent diabetes might be actually. So yeah, super helpful. Well, what else, to conclude, do you want our audience to take away from the results of VESALIUS CV?
That's a really good question. There are many things. I think probably the main next thing, in addition to the findings that we talked about, is just sort of thinking about implementation, thinking about, us as practitioners, really working hard to use the therapies that we are already recommended per the guidelines, and then to add on these to just really, push aggressively to, lower the LDL in these patients earlier, so.
That's great. Well, what a treat to hear such exciting science, and then what an additional treat to have the chance to speak with the co-PI of this trial here today. Really impactful science, and really great to have it here at AHA 2025 Scientific Sessions. So thank you, Erin.
Thank you, Chiadi.